Well, good morning and welcome. I'm Robert Caudell. I'm the program director here at the University of Louisville for our psychiatry grand rounds today. It's my distinct pleasure to introduce our speaker. One of the things that makes you feel old over time and also very proud, however, is to be able to see some of our alumni move on and do great things in the world, and that would include Dr. Megan Good today. She is the medical director of the Spire Clinic at Beth Israel Deaconess Medical Center. She's an instructor in psychiatry at Harvard Medical School. She completed her residency here at the University of Louisville, where she served as one of our chief residents, and she followed this by an early course psychosis fellowship at Harvard Medical School. Her clinical and research work focuses on early psychosis, medical contributors to psychotic symptoms, and improving early intervention pathways for CHRP and first episode patients. She's a dedicated advocate for individuals and families affected by psychotic disorders, and she's also a proud Kentuckian, and we are proud of her. So very interested in seeing what she has to say today. Thank you for joining us today, Dr. Good.
Thank you so much, Dr. Caudell, for that introduction. Can you hear me okay? All right,
Yes.
fantastic. All right. It is good to be back. So it's truly an honor to be asked to present grand rounds in front of my mentors, my friends. Hello, Dr. Summers and Dr. Gundamala, and the department that helped me to become a psychiatrist. I've had the opportunity to do some really cool things in my life, and this is certainly up there. To give everyone a short update on my life, I moved to Boston. My rent tripled and I lost 2 bedrooms. In June, I completed my early course psychosis fellowship, and I took on the role of medical director of the Aspire program, which is Beth Israel Deaconess Medical Center's first episode psychosis program at the beginning of this year. Today, we are going to explore a crucial topic in mental health care: early course psychosis from risk to recovery. Early course psychosis is something that we all encounter often in the clinic, the ED, in the inpatient units. These are young people whose lives are suddenly and profoundly disrupted, often right at the point where they're transitioning into adulthood. What we do in the early years of psychotic illness matters enormously. The decisions we make, the treatment we choose, and the way we engage families can set someone up on a trajectory toward long-term recovery or long-term disability. That's why this topic isn't just academic, it's practical, it's urgent, and deeply relevant to the work we do every day. Today, we will discuss the clinical presentation of clinical high risk for psychosis, or CHRP, syndromes, and first episode psychosis, or FEP, the importance of early intervention, the structure of coordinated specialty care programs, which are the gold standard for first episode psychosis treatment, and we will explore the unique qualities of the clinical high risk population to prove that clinical high risk for psychosis patients are more than a prodrome to psychosis. Specifically, we'll be looking at 2 related populations of patients. Again, the first is clinical high risk for psychosis, CHRP. These are patients who have not yet had a full psychotic break, but they are experiencing a milder form of positive symptoms called attenuated psychosis that puts them at a much higher risk of experiencing a psychotic break down the line. CHRP, or clinical high risk for psychosis, is a clinical diagnosis, but attenuated psychosis is the associated symptom. And second population we'll be looking at is first episode psychosis, or FEP. These are patients who have experienced a psychotic break and are in the early stages of psychotic illness. And in this case, FEP is the diagnosis, first episode psychosis is the diagnosis, psychosis is the associated symptom. An introduction to early psychosis. To zoom way out, psychosis is clinically defined as disruptions in thinking and perception, with hallucinations and delusions as the primary symptoms. When I explain psychosis to patients, I often say that psychosis is like we're both playing the same video game, but by different rules. Psychosis can be affective, which means tied to a mood disorder like major depression, bipolar, schizoaffective disorder, or non-affective, which means that the psychosis is not accompanied by any mood symptoms. And we see this, of course, in schizophrenia. Clinical high risk and first episode psychosis programs both diagnose and treat affective and non-affective psych pathologies. But in the presentation today, I'm going to focus more on schizophrenia spectrum disorders because that is the focus of most CHR and FEP research. Before we continue, let's ground ourselves in the reality of living with psychotic illness. The international prevalence of schizophrenia is 0.33 to 0.75%. So these, as we know, are not rare illnesses. Schizophrenia is a top 15 leading cause of disability worldwide. 100,000 young adults experience first episode psychosis every year. The peak onset is age 15 to 25. So again, when patients are really transitioning to adulthood. And then lastly, 4.9% of patients with schizophrenia die by suicide. The vast majority of this 4.9% are patients who are first episode psychosis. Psychosis is a spectrum. Like most chronic illnesses, schizophrenia occurs in stages. First, we have the premorbid phase, which is the phase that occurs before any symptoms appear. Patients in this stage may have subtle cognitive, social, or motor impairments, but they are non-specific and usually only recognized retrospectively when the patient has had their first break and they're looking back at their life to try to find clues as to why this happened. The second phase is the prodromal phase or the clinical high risk phase. We actually don't use this word anymore. This is an outdated term because it implies that clinical high risk for psychosis, if you're quote unquote prodromal, you will transition to first episode psychosis and develop a psychotic disorder. And that's simply not the case. In fact, I'd be curious, I would like you guys to put some guesses in the chat of what percent of patients with clinical high risk who are prodromal and the old nomenclature actually convert to first episode psychosis. I'd be very curious to see. I don't think I can see the chat, but let me see. I don't know. I can't see it. Okay, so I'll just tell you. So it's actually 20 to 30% of patients who meet criteria for clinical high-risk syndromes convert to a full episodes of psychosis over 2 to 3 years. So that tells us that this clinical high-risk state is not just a precursor to psychosis, it is its own pathology. The first episode phase or the acute phase is the first time a patient has full threshold psychotic symptoms and meets the full diagnostic criteria for schizophrenia. At this phase, patients often have marked functional impairment and a decline in general life status. Early recovery is the first 2 to 5 years after first episode. This is a very crucial time, first 2 to 5 years after FEP, because this is the time where you have the highest risk for relapse, but it's also the place where you have the maximum recovery potential. So this is really where we want to intervene with these patients clinically. And this is also the window where coordinated specialty care, which is the model of first episode care we'll talk about in a bit, is implemented. Lastly, we have the stable or chronic phase, if applicable. Some patients who are in early recovery do recover, never have another psychotic episode again, and go on with their life. Maybe they have other comorbid psychiatric pathologies, maybe they don't, but oftentimes people don't move on to this chronic phase. But people in this chronic phase have persistent symptoms. These are very sick individuals. Oftentimes they're in a bit of a remission, but they still have some residual auditory hallucinations, residual perceptual disturbances, and they need a lot of social support. And they do improve, but that functionality plateaus after a certain extent. What we're talking about in today's presentation is this slice of the psychosis spectrum: clinical high risk, first episode, and early recovery. Early psychosis. When we say early psychosis, this is what we mean. And again, these are the 2 points where we want to intervene, where we can really change the trajectory of patients' lives, preventing patients from converting from clinical high risk states to first episode, and preventing patients or improving their prognosis as they move from early recovery to the chronic phase of illness. Here is an overview of the DSM-5 criteria for schizophrenia. A patient with first episode psychosis would meet all of these criteria and therefore qualify for a diagnosis of schizophrenia. I want to highlight the fact that positive symptoms are diagnostic for schizophrenia and, of course, define psychosis, both affective and non-affective. And this becomes more important when we discuss diagnostic criteria for clinical high-risk syndromes in a few slides. The DSM-5 does make reference to attenuated symptoms, aka that prodromal or those lesser symptoms of psychosis that lesser form of psychosis when discussing illness duration. So the specific line is this 6-month period must include at least 1 month of symptoms that meet the above criteria and may include periods of prodromal or residual symptoms. During these prodromal or residual periods, the signs of the disturbance may be manifested only by negative symptoms or by 2 or more symptoms listed above in the attenuated form. So we are taking into account attenuated psychosis when defining schizophrenia. However, there's also another part of the DSM called the conditions for further study section. And in my mind, I conceptualized this where the DSM-5 committee looked at this and said, interesting. And they didn't want to put it in the book, but they realized like, hey, there might be something to this. We should really keep an eye on this to see if this is something we want to put in our dogma down the line. So the conditions for further study section contains attenuated psychosis syndrome, which is one of the clinical high-risk syndromes. And it's a way to capture the prodrome. And notice that the attenuated positive symptoms and a significant decline define the illness of attenuated psychosis. So it's not just that the person is having minor versions of delusions, hallucinations, disorganized speech. It's that they've had a profound decline. And that's very important when we're identifying these populations who are clinical high risk. But what is the difference between attenuated psychosis and psychosis? When we say this is a minor version of psychosis or this is a lesser version of psychosis, what are we actually talking about? Because even though the difference can be very subtle, it's important because when we diagnose someone with clinical high risk versus first episode psychosis, that's going to dictate what sort of care they receive and the trajectory and the goals of their care as well. Are we preventing them from transitioning from clinical high risk to first episode, or are we trying to improve their long-term trajectory if they truly have developed a first episode of psychosis? So the first symptom of psychosis is unusual thought content. In attenuated psychosis, patients are going to be able to reality check. So they would have some odd ideas, but they're going to have some doubt versus psychosis who are going to have delusional beliefs, a fixed false beliefs that is not altered despite evidence to the contrary. Attenuated psychosis, that's going to look like, I feel like people may be watching me, but I could be imagining it. Again, we're reality checking appropriately. And then psychosis is the government is monitoring me because they want to kidnap me. And that to this person is a reality, is a certainty. Next is perceptual disturbances. And patients with attenuated psychosis, they can have brief, fleeting perceptual disturbances that don't last and that they're still able to reality check. So for what this often looks like in practice is faint whispers. They'll see shadows out of the corner of their eye. They might see flashes. They would maybe hear like a clanging or a bell in the distance, but it doesn't last long and the person is still able to overcome that. Versus in psychosis, we know that patients are hearing voices, they're having full-blown hallucinations. Next is overvalued ideas. Patients with attenuated psychosis are going to have unusual beliefs with some insight. Again, they're reality checking appropriately. They might say, I might have a special power, but I can't be sure. I had a patient with CHR who was having these like kind of like burgeoning thoughts that they were in a simulation, and they were very short in duration, but when they came on, they were quite powerful. But even in the moments when they came on, they were still able to reality check. But this was very disruptive to them because they're like, I know I shouldn't be feeling this way, Dr. Good, but I do. There are times when I am starting to feel more and more convinced that I'm living in a simulation. And again, patients with psychosis have firm delusions with no doubt. They might say, I have been chosen by God to save the world, and no one can convince me otherwise. Next symptom is suspiciousness and paranoia. Patients with attenuated psychosis may have mild paranoia. Consider alternatives. There may be peers at a lunch table talking, and their first instinct is like, hey, they're talking about me, they're whispering about me. And then they're able to pull back and say, well, wait a minute, it's not likely that a whole group of people would be talking about me and gossiping about me. And psychosis patients, again, are going to have firm delusions, no doubts. The neighbors are spying on me and reporting everything I do to the authorities. Next is disorganized speech and thought, and this is often how we first catch clinical high-risk states in attenuated psychosis. Patients may become extremely disorganized in speech and thought. Their teachers catch on to it, their family catches on to it, and they have a decline, often in academic functioning is what people notice first versus people with full-blown psychosis, as we know, can become just completely incoherent and disorganized. And how do we diagnose clinical high-risk states? Because we know how we diagnose psychosis. Patients come into the emergency room. We're concerned that they're psychotic. We do our clinical interview. We do a medical workup, and typically we admit them. We watch them over time. We stabilize them, and then that diagnosis is kind of an evolving process. Diagnosing clinical high-risk states is a little bit more precise. We use something called the SIPS, or the Structured Interview for Psychosis Risk Syndrome, which is actually quite a long and intensive psychological test that patients undergo. And in the SIPS, we're looking for different symptoms. We're looking for evidence of positive symptoms, negative symptoms, cognitive symptoms. We're looking for other psychiatric conditions like mood states. And we're just trying to say, is this a person who is experiencing clinical high risk? There are three specific clinical high risk states that are clinical high risk pathologies that we diagnose. So these are all under clinical high risk, all three of these. The first is attenuated positive symptom psychosis risk syndrome, or APSS. APSS is someone who is having subthreshold positive symptoms. What this often looks like is a college student who suspects peers are talking behind their back, but acknowledges he might be misinterpreting things. He's showing mild paranoia without full conviction. Um, maybe hearing voices, not full-blown voices, but maybe having perceptual disturbances that are brief in nature and that the patient is able to reality test with. That's typically what we see APSS with. And in my experience evaluating these, typically kids, these are typically, middle schoolers, teenagers, late teenagers. This is the one that we diagnose the most. We also have brief intermittent psychosis risk syndrome, or BIPS. Yes, that is correct, which is brief episodes of full-blown psychotic symptoms. So timing is they're very specific with the details of these CHR conditions, because we're really trying to distill and define what makes someone clinical high risk. So there are certain time durations on how long you can be experiencing these symptoms. So BIPS is brief episodes of full-blown psychotic symptoms. An example of this would be for 6 hours last week, a teenager was absolutely convinced her room was bugged, but the belief completely disappeared on its own by the next morning. I had a patient we diagnosed with BIPS who she was convinced that there was a monster in her room and spent the entire night looking in under the bed, looking in the closet, just absolutely terrified, but convinced of this. But in the morning, that belief went away. And it was in the context of other symptoms as well. It wasn't just like a scared child. They were hearing growling, they were hearing um, other attenuated psychotic symptoms. So that's BIPS. And then lastly, we have the genetic risk and functional decline psychosis risk syndrome, or GRD. GRD is a decline in functioning combined with either a family history of psychosis or meeting criteria for a schizotypal personality disorder. So GRD would look like the son of a mother with schizophrenia has recently withdrawn from friends and sports, while his grades have dropped dramatically despite not reporting any clear psychotic symptoms. GRD is included in CHR because we have to accommodate for the fact that schizophrenia is a profoundly genetic disease. Obviously, there's not a direct correlation with a certain gene, but it's profoundly genetic. And no matter what, when we're talking about CHR, we have to include patients who have that genetic risk. Oftentimes with GRD, when we diagnose it, we're seeing it in the context of another CHRP syndrome. So what that'll look like is a patient would be diagnosed with APSS and GRD. Oh, I meant to have pictures with these. All right. And then the last diagnosis we can make on the SIPS is POPS, which is the presence of psychotic symptoms, which means that you have met criteria for full threshold psychosis. You do not qualify for a diagnosis of a clinical high risk syndrome. We need to refer you to a first episode program or first episode care. It is undeniable that early intervention and psychotic illness improves lives and leads to meaningful recovery in both clinical high risk and first episode psychosis. Just wanted to flash back to compare these two clinical states. So we have clinical high risk, aka in the old nomenclature, the prodrome, which is a deviation from a patient's previous experience, and that puts them at a higher risk of developing psychotic symptoms down the road. FEP is, of course, first episode is the first time a patient experiences true psychosis. And then you can compare the symptoms back and forth. Again, clinical high risk, there's a lot more of a focus on decline, on progression, versus first episode is more about those classic psychotic symptoms we see and improving functionality. But why do only certain people? Again, we know that 20 to 30%, it's really more of the 20% end with the most recent research. Why do only 20% of these clinical high risk patients convert to a psychotic disorder? And we don't know 100%. If I knew, I would be holding a Nobel Prize in my hand right now. But the truth is, we really don't know. We do, however, know that there are risk factors that significantly increase the chance that a patient will convert. And we'll talk about some of these now. These are just a few of the predictors of transition to psychosis. In psychiatry, we of course have the stress diathesis model, which is the interaction between biological vulnerability and environmental stressors, which can trigger a psychotic break. The first predictor of transition to psychosis is genetics. So individuals with a first degree relative have a higher risk. Again, schizophrenia is profoundly genetic in nature. There are 126 candidate genes that are likely involved in the development of psychotic symptoms in some manner. But the thing is, those genes also overlap with other diagnoses like addiction, like major depression, like OCD. Interestingly, we know there are specific genetic conditions that have a higher increased risk of schizophrenia development. So 22q11.2 deletion syndrome, or DiGeorge, 25 to 30% of those patients develop schizophrenia. Development is the next predictor of transition to psychosis. Perinatal complications such as hypoxia, low birth weight, maternal infections, and utero exposures, as well as delays in language, motor skills, and social interactions can also predispose patients to developing a psychotic disorder. Functional decline is next. You could argue that this is just an innate part of the clinical high-risk phase, but we do include it as we almost always see a deterioration in academic, occupational, and social functioning in clinical high-risk patients. Substance use, frequent cannabis use especially. We know that high THC strains increase the risk of developing psychosis by 5 times. This is especially the case if a patient starts this behavior before age 15. And as we know from EPS, other substances such as methamphetamines and hallucinogens can also induce psychosis in patients. And of course, we know that there's substance-induced psychosis in and of itself as its own category. But what I see and what we see in clinic a lot of times is patients who are smoking cannabis from a really young age. That is maybe the trigger for their first episode, but then they do go on to develop a chronic psychotic disorder even after they're sober from the substance. Trauma is next. No surprise that early life trauma, such as abuse, neglect, and bullying, can lead to increased risk of transition to psychosis. And then lastly, neurobiological risk. There are certain changes in the brain that do correlate to development of psychotic illness. And sometimes people show those at baseline, such as reduced gray matter in the prefrontal cortex and the hippocampus. So what I want you to take away from this slide is that most at-risk individuals do not develop psychosis. In fact, it's 20 to 30%. Really 20 is the number I would cite now. And patients who do have more of these risk factors do have an increased likelihood of conversion. And the whole thesis statement of clinical high risk for psychosis treatment is that reducing risk factors improves patient prognosis and will hopefully prevent that transition to full episode psychosis. I also want to point out that one of the tricky parts of CHR and studying CHR, treating these patients, is that this is an incredibly heterogeneous population. Some patients are clinical high risk because of their genetics. Some are clinical high risk because of their high cannabis use. Some are clinical high risk because they're autistic and they have developmental disabilities. So it's really hard to pick out what exactly makes someone clinical high risk, which factors are more risky than others. And we also know that these patients usually almost have psychiatric comorbidities as well. So we see a lot of depression, we see a lot of OCD, we see a lot of bipolar disorder, a lot of cannabis misuse. So you're really looking at these complicated patients and trying to distill what does clinical high risk actually mean. These are some of the more common comorbidities that I've seen in these patients. All right, moving on to early intervention with first episode psychosis patients. So again, early intervention is crucial. So 2 crucial metrics in understanding psychosis treatment outcomes are the critical period concept as well as the duration of untreated psychosis. The critical period concept suggests that the early phase of psychosis and the prodrome represents a crucial window during which intervention can significantly alter long-term trajectories of illness. And again, this is the entire thesis statement between coordinated specialty care, first episode treatment. The duration of untreated psychosis is the time period between the onset of psychotic symptoms and the initiation of appropriate treatment. And I want to call your attention to the fact that in patients, this is 1 to 2 years. These patients are really suffering and struggling for a long time before they get access to care. And why is that? Oftentimes, it's a lack of awareness about early psychosis and what's really going on. Stigma prevents help seeking. Sometimes there's limited access to specialized mental health services for these first episode patients. And oftentimes there's also a misdiagnosis. We see that negative symptoms are often misdiagnosed as autism, for example, or subtle attenuated psychosis or subtle psychosis can look like, ADHD. Like people get misdiagnosed. I want to illustrate the critical period concept and the duration of untreated psychosis on our stages of schizophrenia. The green oval is our critical period, which spans from the prodrome or CHR period to the end of the first episode period, which again is typically 2 to 5 years after the first episode. The first arrow is our first episode, and the second is treatment initiation. And the period between these is the duration of untreated psychosis. The goal is to reduce that duration of untreated psychosis in order to improve long-term trajectories in care. All right, let's move on to coordinated specialty care, which is the specific model that we use to treat both clinical high risk and first episode psychosis, and what I'm lucky enough to get to do that every day. So coordinated specialty care, or CSC, is a multidisciplinary team approach to treating patients with early psychosis. This is a care model developed specifically for first episode psychosis, but over time, clinical high risk for psychosis treatment has adapted and modified coordinated specialty care to suit their needs. And there are coordinated specialty care programs in all 50 states. The structure of coordinated specialty care programs is a multidisciplinary team. This is an attempt to address all aspects of a patient care. The team works closely together with the patient and their family and enacts group decision making. The members of the care team in the program of FEP, CSC, and coordinate or CHR, CSC are similar, but there are a few differences that I will point out. First, patients get a psychiatrist. We'll talk a little bit in the next slide about medication management of first episode patients and clinical high risk patients and how they differ and how they are similar. Next, the patient also gets a psychologist or a therapist of some kind. Oftentimes, these therapists practice CBTP or cognitive behavioral therapy for psychosis, which helps patients challenge distressing thoughts and improve coping skills when they are experiencing psychosis. Next is a case manager. Case managers help with housing, finances, insurance, and daily living needs. Patients also get an employment and education specialist, a job coach. These are individuals that can help patients with vocational training, job coaching, academic support if they need, if they're going back to college and they need, the word's not coming to me, but they need accommodations. There we go, accommodations. This is someone who can help with that. The CSC programs also have peer support specialists. These are individuals with lived experience who have undergone special training to be a support for these patients. And peer support specialists are particularly helpful when patients are coming into the clinic and maybe they're not as enthusiastic about engaging at first. Oftentimes, peer support is the person who can come in there and make the patient feel welcome, make them feel heard, understood, etc. And then lastly is a family educator. Family education and support. This person is there really to reduce stress and enhance communication skills with families and patients. Oftentimes what we see happens is there, of course, just in the lay public, there's a lot of misunderstanding behind what psychosis is, what it isn't. And a lot of times it falls on the patient themselves to educate their family about their condition. And that can be really difficult because they're simultaneously trying to recover and live the condition and trying to explain it in ways that maybe they don't even understand yet. So the family education and support person can facilitate some of those conversations. I want to draw your attention to two aspects of clinical high risk for psychosis coordinated specialty care programs that are different from the first episode psychosis components. These are assessment and monitoring as well as resilience training. Again, remember our thesis statement with CHR is that if we reduce risk factors, if we encourage resilience, that hopefully this patient won't convert to full episode of psychosis. So that's what the resilience training is focused around. We're also assessing and monitoring these CHR patients a lot because we want to see where their symptoms are. Are they headed towards first episode psychosis? Is their depression worse? Like what is happening with this patient over time? And you're really tracking that because your end goal is you do not want this patient to convert to psychosis. Let's talk about pharmacologic management and clinical high risk patients versus FEP patients. So CHR patients, we actually don't want to use medication first line. So we use a lot of psychosocial interventions, family therapy, CBT, supported employment and education. And we're often treating comorbidities. So we're using antidepressants to treat depression and anxiety. We're using sleep medicines if the person is having issues sleeping. Um, if they're having ADHD, we're very carefully managing that. Overall, we're not really using antipsychotics in the CHR population, and that's because conversion rates are low. And if we're taking more of a harm reduction stance to medication management, the metabolic and neurologic side effects of these medications could be more harmful to this very young population who may not even convert in general, but this may be just their present state of now. First episode, Psychosis, we are using antipsychotics, but our dosing principles are we're starting low and we're going slow to titration. We know that FET patients respond to much lower, usually even subtherapeutic doses of antipsychotics than their counterparts who are further along in their illness. And we also consider LAIs if there are adherence issues. This is our crew. This is the Aspire Clinic. The people I'm lucky enough to get to work with every day. I just wanted to talk about the structure of coordinated specialty care in the context of what we do. So this is our leadership team, Faith Breisblatt. She is a social worker, and our clinic director, Dr. Sarah Harold, one of my mentors, Dr. Roscoe Brady, and myself. We have some faculty members and researchers involved in our clinic. Most of our patients are involved in research, which is pretty cool. This is first is Dr. Macheri Keshavan. He's like essentially the grandfather of a lot of this work. He founded one of the first coordinated specialty care programs at the University of Pittsburgh, and then he came to us where he's continued his robust research in clinical work. Dr. Louise Sandoval, who is a psychologist who looks at cognition in schizophrenia, and then another one of my mentors, Dr. Paolo Lozano, who looks at visual and perceptual disturbances in psychosis. We also depend a lot on our trainees. We have both resident physicians. Those are the three that are currently rotating with us. And we also have PhD, PsyD, and LICSW trainees. Um, we have some research assistants and support staff. This is not everybody, but we have school and work coaches. We do a little bit of everything. And something that I really love about our clinic is we try to involve patients in development of our programming. So for example, 28% of our patient population is LGBTQ. They requested a specific group. They said, hey, this is something we want to talk about, something we want to do. And some of our psychology trainees have that interest as well, and they've started that group, and it's been very, very popular. And it's been a really great place for the patients to find to find fellowship among themselves, to find belonging, etc. And you have to think these aren't just patients with psychotic disorders, they're full human beings with lives and passions and dreams. And we want to support them however we can, even if it's in a realm that's outside of psychosis. Talking a little bit about the history of coordinated specialty care, just because I think it's important to know where we've been so we understand where we're going. In 2008, the NIH started the RAISE trials. So the NIH said, hey, we have a lot of people who with schizophrenia who are very, very ill. How can we improve the prognosis of patients who unfortunately develop this illness? How can we improve their prognosis down the line? And they developed coordinated specialty care as a concept. RAISE was the initiative to study this concept in practice. And then that continued with the STEP trials. STEP was looking at coordinated specialty care for clinical high risk for psychosis patients. So again, we're looking at the CSC model in first episode, and then we're looking at it in coordinate in CHR. Next, I just want to point out a few things on this timeline. Over time, these clinics have spread across all 50 states. In 2019, EpiNet was established. EpiNet is the network of coordinated specialty care clinics across the US. It's important to connect these coordinated specialty care clinics because we want them practicing evidence-based care that's dictated by the NIH. They share research, they share data, they share, a lot of different resources between them. So it's really great that these occur in a community. In Massachusetts, we have our own network of coordinated specialty care clinics. It's called MapNet, and there's like a statewide research effort with that. Again, resources are shared, a lot of education between clinics. That's a really great thing. Collaboration, I think, in general in medicine is a very good thing. And then lastly, in 2020, the APA practice guidelines recommended that every patient who experiences first episode of schizophrenia be treated in a coordinated specialty care programs. It is the gold standard for patients with first episode psychosis, and truly every patient deserves access to a high level of care. The question is, does coordinated specialty care work though? Does it work for first episode psychosis? Does it work for clinical high risk? And the answer to that question is that yes, coordinated specialty care does work. There's robust evidence dating back to the original RAISE trials demonstrating the efficacy of coordinated specialty care and improving the lives of patients. These are just some of the effects of CSC. We see decrease in symptoms, decrease in hospitalizations, decrease in financial burden, decrease in structural brain changes and suicide risk and all-cause mortality. We also see an increase in treatment response and functionality and long-term prognosis. But the real answer to this question of does CSC work for first episode psychosis is yes, but because over time we found that coordinated specialty care programs, as they currently are set up, which is that they are 2-year programs and then patients graduate to the community and are treated there, the benefit typically lasts a short term of 2 to 5 years. So short-term improvement, and it requires continued intensive care to sustain the benefit. It's almost like schizophrenia for most people is a chronic long-term condition that requires a lot of care to retain stabilization. But what do I know? Something that in our clinic, knowing this, because we do value research and we do value the field, and we want to contribute however we can to best serve our patients. This year, we've started something called NEST, which is Next Specialty Care. So patients who are in our clinic who have done the whole program, they're doing a lot better. Usually people are back in school, they're back at work, they're doing quite well, they're dating again. They're doing well. They don't need all aspects of the program because these programs are intensive. Like people are coming to us usually 2 to 3 times a week for various services, but they don't need that level of care anymore. So what we've decided to do is found a step-down clinic where patients can see a psychiatrist that's familiar with them, that can manage their clozapine, that can manage their LAI. And if the patient were to start decompensating, we could always rotate them back into our clinic, into a group, into an individual therapist, so they could receive a higher level of care from providers who are well versed in treating psychosis and specifically first episode psychosis. Next question, does coordinated specialty care work for clinical high risk for psychosis patients? Extremely mixed results, if I'm honest with you. Again, our goal with CHR is to prevent conversion. We know that in the time, like in the space that patients are in these programs, they're decreasing symptom burden and they're increasing functionality. So patients, again, do really well while they're in these programs. However, there's little evidence for preventing transition to psychosis. And I have a few theories as to why this is. One is that, again, this clinical high risk population is so heterogeneous that it's like, how do we know we're looking at the right people who, in terms of who has the highest chance of conversion to first episode psychosis? This is something a lot of people who are very, very smart, very, very capable, very, very passionate about this work are trying to do. They're trying to figure out how do we target patients who are truly at the highest risk for conversion to psychosis. All right, and what that comes down to is ultimately we have work to do. So in this slide, this just sums up everything we've talked about, comparing clinical high risk to first episode psychosis. 20% of patients who are clinical high risk convert to first episode. A target population of clinical high risk are people with genetic risk, people with attenuated symptoms, versus patients with first episode have, of course, reached that full threshold for psychosis. Symptoms in clinical high risk states are going to be subthreshold. Symptoms in first episode will be full threshold. Treatment of clinical high risk revolves around reducing risk factors and reducing stress. So we're doing a lot of therapy, we're monitoring, we're doing family education. First episode is about coordinated specialty care, really that multidisciplinary team, bringing that together to get the patient back to their functional baseline. Service intensity of clinical high risk, it's lower. I'd say people are coming, at least when the clinic I was at, people usually came multiple times a week, but from my understanding, that's not always the case with clinical high risk. Service intensity for first episode is very high. So patients are coming to our clinic 3-4 times a week for various services. And then challenges with each clinical high risk, identifying who is actually going to transition, who is at the highest risk. And the key challenge of first episode is engagement and long-term recovery. Dr. Caudill, do I have until what time do I have until?
We are done at 1 o'clock.
Oh,
So
okay.
we have some time for questions if you wish.
Yeah, I have a couple more slides. I just wanted to make sure I wasn't going to run over. Okay, great. Yeah. So I have a few more slides. Something that I'm really interested in is, again, clarifying who is part of this clinical high risk group, because we have a lot of risk factors that we know of, but how can we distill these risk factors and these very heterogeneous population down to a common thread that unites them? So CHR truly is more than just the prodrome to schizophrenia. Again, it's not a prodrome, because if it was a prodrome, everybody that was clinical high risk would convert to first episode, and they don't. This is its own unique disease state of attenuated psychosis. And one of my mentors and we just finished up a project about medical comorbidities and medical contributors to clinical high risk for psychosis. And I just wanted to talk about it briefly because I find it really interesting. So CHR, again, remains a distinct clinical entity with unique needs. We don't have a standard medical assessment. The big picture with this project is we don't have a standard medical assessment for clinical high risk because we don't even know what medical conditions it's most associated with. We know that when patients come into EPS and it's their first episode, we're running labs. We're running labs, and then we're admitting them. Hopefully we're getting them head imaging. We're trying to see if there's any medical contributors to their current state. And clinical high risk, there's just no protocol for that. And in my opinion, there needs to be, especially as we're learning more and more about a very unique patient population. So what we did was this was with the MGH Reset program, which is a clinical high risk for psychosis program in Boston. We teamed up with McLean Hospital, and McLean Star, which is another CHR program, and we did an EHR review of patients who had been evaluated for clinical high risk for psychosis. We looked at a few different endpoints. We had 185 patients aged 12 to 30. We looked at a few things. We looked at one broad category of what workup people are doing and what medications these patients are getting before they're evaluated for CHR. And we also looked at a couple of different medical endpoints like metabolic indices, inflammatory markers, head imaging, et cetera, and also medical comorbidities to see if there was anything we could find that was significant. So and then we grouped the patients into 3 categories based on the SIPs. So clinical high risk, patients who met criteria for psychosis, and patients who were clinical controls, who were people who just did not meet criteria for clinical high risk syndrome or psychosis. They had something else, usually OCD, usually autism, something along those lines. Most interesting things we found was that clinical high risk patients had higher incidences of head injuries, migraines, obesity, and vitamin D deficiency, even when controlling for antipsychotics. So that was interesting. Again, 13% of patients with clinical high risk had a head injury or a concussion versus only 7% of patients with psychotic disorders, which is interesting because we know that head injuries are a risk factor for later developing psychosis. It's usually not the only thing that would trigger someone to develop a psychotic disorder, but it's usually a contributing factor. Some of our results weren't as remarkable. We found that as far as inflammatory markers, which we looked at white blood cell count, CRP, ESR, and neutrophil lymphocyte ratio. Neutrophil lymphocyte ratio is something that people are starting to look at around like first episode because they're finding that if it's elevated around the first episode, then it can be kind of a warning sign that it's impending, that someone is becoming psychotic, essentially. We did find that in psychosis, neutrophil lymphocyte ratio is highest, versus CHR was second highest versus control was lowest. However, any differences we found here were better explained by antipsychotic use and age um, rather than actual differences between the groups. Metabolic markers were similarly not as remarkable, but we of course wanted to see if there were any baseline differences between the groups. So we looked at lipid panel, we looked at BMI, hemoglobin A1C. And then something interesting we found with utilization of resources was that 27% of the clinical high risk for psychosis patients had an MRI already before they were evaluated for clinical high risk versus only 24% of patients who qualified for a psychosis diagnosis. So we thought that was interesting. And then as far as prescribing patterns and medications, clinical high risk patients and psychotic patients had similar rates of antipsychotic prescribing before they were seen by these specialty clinics. So in the community mental health sector, people are they're using antipsychotics as soon as they suspect that this patient may be having some sort of psychotic illness. So conclusions. One is that early intervention is crucial. First, we talked about conceptualizing early psychosis. We talked about our two patient populations, clinical high risk, who are individuals who experience what are called attenuated symptoms, meaning they're like psychosis light. 20% of these patients convert to true psychosis. First episode psychosis are patients who do cross that boundary from CHR, and they experience a first psychotic break and do experience psychosis. Early intervention is crucial. It changes the trajectory of patients' care and their prognosis, especially early on. And coordinated specialty care is the model through which we offer first episode and clinical high risk patients care. It includes offering them a multidisciplinary team to address all aspects of their care, and regaining functionality is really the focus. For CHR, coordinated specialty care, the point is hopefully to reduce conversion to first episode and also to reduce risk factors for conversion and reduce stress. There's robust evidence for the effectiveness of first episode psychosis coordinated specialty care. Not so much with CHR. We know it improves functioning in the short term, but in the moment that you're taking, but not really when you look ahead at all. And unfortunately, we're not seeing a lot of evidence that it prevents conversion. And then lastly, we looked at some of the medical comorbidities and contributors to early psychosis in a recent project of mine, mainly that head injury. And we found that head injuries, obesity, migraines were more common in the CHR population. And we also saw that antipsychotics are being prescribed for these CHR patients in the community, even though that's not necessarily recommended. At this time, I'm happy to take any questions. I'd like to dedicate this presentation to my sister Lauren, who's my first and most personal reason for doing this work. I'd like to also thank my mentors, past and present. Many of you are in the audience. I tried to get everyone's name. I apologize if you're not on the list. Like I promised, I thought of you. But it's like I said, it's wonderful to be back. I'm extremely honored. Yeah, thank you.
Thank you, Dr. Good. That was an incredible presentation. If anyone has questions, please just raise your hand and I'll promote you to panelist, or if you want to put them in the chat, you can do that as well.
Hey, Dr. Good.
Hey, it's so good to see you.
It's good to see you. It's good to see you. Thanks for coming today and for sharing this with us. It was really interesting and great to see all the work you've been doing these last couple of years. And I have a question as it relates more so to the first episode psychosis group, I guess, as opposed to the CHR group. But um, in that group of first episode psychosis patients that you all work with, I'm just curious if any of them have or if you've seen any benefit in that specific population with Cobenfy, or if that's something you've even been able to attempt given, issues around cost and things of that nature. I didn't know if perhaps some of those patients were really struggling to tolerate, traditional antipsychotics, and you all had experience with Cobenfy as an alternative.
Yeah, I'm really glad you asked about that. I've had two patients on Cobenfy. Neither of them have been able to tolerate it due to side effects. One had really horrific vision issues. Like I was actually really concerned he had angle closure glaucoma, but he did not, thankfully. And then the other just had really bad nausea that didn't go away. I think they say like it could go away, but he was on it for months and it unfortunately wasn't helpful. But I think the way people that I've worked with who are using it, people are using it as like a treatment resistant drug, and it's not like it's not meant to be used like that. But of course, access to new drugs is really difficult to come by no matter where you are. I unfortunately haven't had a lot of experience with it in the long term, like enough to see if there's been any results.
All right, thank you.
Yeah. Have you?
I've had a couple patients on it. Not overwhelming results thus far. The reason I asked this question is because there has been one patient that falls in that sort of early, psychosis sort of age group, early 20s, and a couple of hospitalizations and things of that nature, I've had a lot of trouble getting him to continue taking any sort of, antipsychotic dose of an atypical antipsychotic or whatnot, just because of side effects, and have him on Cobenfy, and again, kind of mixed results so far. So,
I gotcha. Thank you. Hi, Dr. Strauss.
Hi, hi, Megan. I really enjoyed your presentation. I had a question though. Who funds your clinic? Is that something you get from NIMH or from local sources? And again, you get the sense of this national network. Could you say a bit more about how that really works?
Yeah, absolutely. So there's quite a few of these clinics in Massachusetts, and the state has a vested interest in mental health, and it's they have like a pretty robust funding system for these clinics specifically. Our clinic is funded mostly by our department, um, which is great. I love that they're supportive of our work. It's also, I think they find obviously the work we do to be really valuable, but it's also a lot of the researchers associated with our clinic, they work with our patients, and our patients find that experience really valuable. People come to us because they want to work with some of the people that do their work in our clinic. So it's a little bit of everything here and there. We're trying to write some grants to cover some different things that we would like for a clinic, but mainly for us personally, our department, but mass health as well, or like the mental health care system in Massachusetts.
Thank you.
Hi. Just wanted to say thank you so much for giving your talk today. It was great. It's great to see you're thriving in Boston and doing so well. And I got the chance to work with Dr. Harrell and Dr. Brady too. They're just amazing. So I'm really glad you're at the Aspire Clinic and doing well.
Yeah, thank you.
Just wanted to also kind of ask a quick question, piggybacking a little bit after Dr. Bilbro's question. But do you have, I guess, for particularly the first episode, psychosis patients, do you have like kind of certain medications, antipsychotics that are like your go-tos, like that you find to be more effective? And I know you said low doses are better in this population, but like how low do you go?
Yeah, I know, because here I'm still like, they use like very low doses. Like the people I've worked with use like very low doses, like below like a Vilify like 2 or like a Vilify 5 for people. Um, and I think at this point I've kind of like started practicing with like a harm reduction model in place of, we want patients to be on as low doses as effective as possible. So of course, like kind of sticking to the second generation antipsychotics. We will, Abilify, Latuda, um, that in that realm, and then kind of moving then towards like risperidol, olanzapine, and of course, like it matters how symptomatic someone is as well. Something that's been really interesting, and this is something Dr. Lozano kind of instilled, and something that's he's seen a lot of effectiveness with, but when do you take someone off their antipsychotics, that it's not necessarily a lifelong thing. Like if someone's been on antipsychotics and they're on a low dose, you've brought them down over time and they've not been symptomatic. Like after a year, he's taught me to transition people to Lamictal or lamotrigine. And that's something that makes me feel a little nervous, but it's something that I've seen actually like work quite well. So yeah.
Yeah, and that's kind of cool and interesting that the focus is more on treating the comorbidities for like the clinical high risk group and not so much like, yeah, jumping to an antipsychotic right away. Because I think probably my impulse would maybe be to do that, but you're right, there's like a lot of kind of harm reduction that you could be doing instead.
No, it really helps patients feel like, buy into their treatment and feel like they are making choices that are benefiting them and they have a say and they understand like what they're putting into their bodies. And these medications are so helpful, but they have this, we do like the dialectics thing of two things can be true. Like this medicine can be insanely helpful and save your life, and it can have these side effects. So how do we reduce that so you feel like yourself and there's not like cognitive side effects and things like that?
And for families too, I know parents were always worried about that as well.
Okay.
Well, thank you so much. Appreciate it.
So good to see you.
We have a
I think
question in the Q&A.
Okay, let's see. So Dr. Sheed says, thank you for presenting on this. I am very interested in this topic, and I'm curious about your experience with initiating discussions about coordinated specialty care with patients' families. I have run into stigma and resistance from early young adults patients when attempting to discuss diagnosis and coordinated specialty care programs. Is this something you all find to be common, and is there anything you found to be helpful in navigating this, especially since we know early intervention is so crucial for this patient population? Let's see. Yeah, I mean, I think this is something that patients who, especially coming out of inpatient units, it can be difficult because at that time people are really still regaining their insight and regaining their sense of self. And they don't want to hear it. They're like, I don't want to hear, about continuing a program that's very intensive and is going to require this much of my time, that can be like a tricky way to have to do is engage them in treatment. Most of our referrals actually don't come from inpatient units, believe it or not. Most of our referrals are from the community. They'll be from like partial hospitalization programs where people are stepped down from inpatient and then they're finally in a good place to participate in coordinated specialty care, or they'll come from community centers or community mental health people. That's where we get most of our referrals. We've been trying to increase referrals from inpatient units, actually. It's been like a job recently. But one thing about these clinics that's true above all else is that the patient has to be willing to participate. Like it takes a lot of motivation and a lot of involvement to do one of these clinics because, like I said, you're coming in like 3 or 4 times a week. And when I say coming in, it means you're meeting with someone. So a lot of it's virtual, of course, but what we tend to do if we're sensing that someone is completely uninterested, like the patient is just not gonna participate at all. I don't know if that's like someone we could ultimately work with. We always want to leave the door open and say like, hey, please, like if this changes, please come back. But even if the patient's willing to just start coming to therapy and start coming to psychiatry, we try to work with them and build rapport over time. And we try to engage family in the early stages as well. We have what's called a multifamily group, which is a bunch of different families, and they meet, and the point of the group is for them to discuss their experiences with, and the patients are there too. It's like family and it's like the patient and their family. The point is education, and it's also for them to discuss their experiences. And if we can get them coming to multifamily group pretty early, oftentimes that's really helpful, just because they realize they're not alone and that community is just so important in recovery from psychosis.
Great. If anyone else has any final questions, raise your hand and I'll promote you. Right. And then Rabani, I tried to promote you because your hand is raised, but it looks like you declined. So if you do have a question, you can accept, but otherwise I don't see any other questions. Okay, I don't see any others. Well, thank you so much, Dr. Good. It was an incredible presentation. I learned so much. I know our residents did as well. And it was so good for you to come back and join us and us to get to see all that you're doing. It's very cool. So thank you so much.
Thank you.